And her background, undergraduate and graduate, she's done psychology, and then and Andrea has accepted a PhD. And so she did her PhD at UVic, and then after that, Helen research has been focusing on the topic related to human factors and digital health literacy and user experience, usability design. She primarily studies consumer health informatics, health mission to improve the health information system by making them easier for people to use and the information easier to understand. So she has got many publications and quite an enviable one. And one of her publications has been referenced in CDC, for example, about health literacy and the definition of it, which I'm very proud to see that the persons from UVic, is being promoted in an international stage. So we're proud to have her to give this seminar. I normally don't invite Helen to the seminar, but this year, I think she has proven me wrong all the time. So I'm very delighted that she's here today and give this seminar. Thank you, Helen. Go ahead.
Thank you. Thank you, everyone.
I know my introduction doesn't justify you, but yeah.
That's okay. Thank you so much. I'm so happy to be here. And yeah, I'm going to share some of my research. Some of you may have seen some of it before, given where I've seen you throughout the world and in life. But I am adding some new stuff that is just under review recently. So let me just begin sharing here. Okay. Right. Here we go. Okay, so today we're going to talk about ways we can improve laboratory results displays for health consumers. We're going to talk about different displays. We're going to talk about different challenges that people have faced based on basically just mostly a pilot study that I did, but I'm hoping to build this out and explore things more rigorously as well. As Abdul kindly mentioned, I'm really into human factors. It's basically how I view the world, is that humans have capabilities and limitations, and design is there to help us leverage our capabilities and minimize our limitations so that we can operate most effectively in the world. And in some cases, we're doing that. And in some cases, there's lots of room for improvement. I believe that lab results are one of the areas we could focus on. As also mentioned, most of my work is in the consumer health informatics space, but I do some work. I'm collaborating with Dr. Blake Lesseroth on some telemedicine stuff, and also other areas of clinical informatics as well. But yeah, I love user experience, information visualization, and think that digital health literacy is so important and can help us build systems. So what I'm hoping you'll learn today is that it's really easy for regular people and even sometimes healthcare providers to overlook abnormal values. And a lot of that relates to how they're displayed to us. We know that different systems will display things differently, but I'm going to give you one of the most popular examples in Canada, and it's pretty close. I just checked the other day, and it's still quite similar. There are very minute differences in how it's displayed, but for the most part, it's pretty similar. We're also going to look a little bit at lab graphs because that adds a different layer of complexity, and I'll share some of my preliminary findings. Like I said, they're under review at the moment. We're going to generally talk about some potential solutions for how design could help us overcome some of these challenges and help us communicate things more effectively to our health consumers. And we're also going to have a discussion with you. So some of you are healthcare providers, some of you are health consumers. So everyone has a say here. And I'm hoping I have some lots of actually opportunities for us to have some interesting discussion and get your different perspectives, because I think we all experience the world a little bit differently, and there's lots for us to learn from each other. Okay, so if for those of you who haven't been on a Zoom talk with me before, I love doing chat box activities just to make sure everyone's paying attention and you can still use your keyboards. So if by way of chat box, can you let me know if you've ever looked at your own lab results? So clinicians, step out of your regular role. Thank you. Oh, yes, 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 yes. Look at this. Amazing. Yes, but not often. That's okay. Even once is enough. Perfect. We got raised hands. This is amazing. So we are all health consumers. And this study is mostly, like I said, it was a pilot study exploring a bunch of different displays. And I looked at different aspects of each of them, which I'm going to share with you. But some of the things you should know is that I had 25 participants, and the data was collected kind of in the heat of the pandemic. So these were conducted virtually, these interviews. And everyone that I interviewed had experience using lab results before, and most of them used them fairly often, so a few times a year. So they were fairly comfortable with them. They felt good about their use, but they also really wanted to participate in the study, which means that they had things to share with me. So I did an interview, but mostly what I'm going to focus on in this component or this talk is I showed them 4 examples and had them do what we do often in usability. It's called a think aloud protocol. So what we do is we show someone a system, or in this case, it was just a display. And I said, I'm going to show you an example. I'd like you to pretend that these are your results. And please think aloud and walk me through how you'd use them. So what you're looking for, what you understand, and what you might find confusing. So just as they would in the real world, I'm trying to get them to articulate or verbalize what they do. So when I showed them each of these examples, so they did the think aloud first, and then I asked them specific questions to check on how they were understanding the examples. So for the first one, I asked if there were any values outside of the reference ranges. The second time I asked them, so they could keep seeing it each time, because I was in control of it. And if these were your results, what would you do next? So looking at follow-up intentions. Then I asked them to talk about what they liked and disliked about the results, and if they had any ideas for improving them. So you're all going to participate today. Don't worry, I'm not collecting data, but it will give us a good exposure to see what the participants saw, and also build some empathy about why these things might be hard to do. So what I'd like you to do is I'm going to show you an example shortly. You don't have to think aloud, but you can as long as your microphone's off. And what I want you to do is if you see any lab results that are outside the reference ranges, just jot them down somewhere on your notepad or something. Don't put them in the chat yet, because we're going to take these up in a moment. So this is our example. It's a pretty long one, so bear with me. Okay, that's it. So if you saw any, jot them down. Like I said, it's a pretty long report, but maybe you saw some stuff, maybe you didn't. But here's the answers. Here's the answer key. So 3 results were high. You saw 127. Okay, I'm not sure. 124. Okay, so Simon caught that one. That's great. Potassium was just a little bit high, and hemoglobin A1C was also right on the threshold, so it was flagged as high. So these little HI are what are used as flags. It depends a little bit on the context. So this was actually the Ontario example, but in BC, we usually just see A's. But here's something that I didn't even realize until my participants started going through. And this is the thing, is that sometimes we don't know what we don't know. And this happened to me a couple times actually in this experiment. So here we have an EGFR result saying that we're in that window between 45 to 59 milliliters per minute per 1.73 meters squared. And it's consistent with mild to moderate decreased kidney function, but there isn't a flag. So if you didn't catch it, that's okay. And now what I like you to do is just come up with what your score was. So this is an error rating score or an error score. So if you got them, you get 0. And if you missed them, then you get 1. So if you got the hemoglobin, 0. If you missed it, you get 1. And then I also, when I was looking at participants, some of them had false positives. So they identified something as being out of range when it was actually in range. So I included those as errors as well. So now we can pop to the chat box. And did anyone overlook one or more of the flagged results? Oh, yes, yes, yes. Yes. And here I am in virtual room with some of the brightest minds in the world. Okay, yeah. So maybe if we had more time, for sure, that's fair. So in the experiment, they had as much time as they wanted. It's hard for me to gauge how long. But yeah, so most of us made some errors, and that's okay. But that's just showing how they're not really doing us justice. They're not doing what we want them to be doing and communicating information. So now I have a few questions for you. If anyone wants to raise their hand and talk about their experience, that's great too. Or we can just keep going with the chat box. That also works. But I'm just wondering if you have ideas about what you think made it hard. So one person mentioned time. So I totally understand that, but let's keep that one out. Let's think more about how they were displayed, if there was anything that made them not pop out at us maybe as they could. It would help if they were in bold, yeah, versus the normal range in another font. A lot of information, yeah, very long report, no focus on pre-attentive details. Dr. Leslie Roth knows what's happening here. Yeah, they weren't color-coded. Oh, hold on, David had something good to say here. Doubt most patients understand context and can interpret unless they have a chronic condition and are monitoring 1 or 2 items that their doctor or nurse practitioner advised them to watch. Not the easiest display, but none are unless one is practiced at this. Absolutely, David, I think that's a great comment. And actually many of my participants did have chronic conditions and were watching things, and sometimes they would put their own spin on the examples, which was helpful and not helpful. But so yeah, so some people times we get more versed in these things. Over time. Okay, one of my physicians added a portal with a dashboard option. It showed a line graph where I fell in between the range. Okay, that's great. Thanks, Nam. We're going to see something similar to that a little bit later. Would never have caught A1C because it was right on the cusp. Absolutely. That makes sense too. Okay. And so David mentioned some of this. It's hard for us to understand context because we aren't healthcare providers. Many of us health consumers, some of you are, some of you play both roles, but context can be hard. Is there anything else that you think makes it harder for health consumers to understand these reports? Or that one, for example? Okay, nothing yet. Okay, well, I'll give you some of my ideas in a moment. Any ideas on improving the report? So we talked about color coding, bolding. Yeah, if you have an abnormal result, what does it mean? When do you need to pay more attention to it? Absolutely. Any findings should have explanation, follow-up recommendations, up and down arrows, above and below range. Oh, you're all, if people Google, they might get the units from the US lab reports, not Canadian units. That's great. move the out of range to the top, reorganize. Oh, you are all so amazing. These are great. Medical terminology, absolutely. There's lots of acronyms in there. Knowing to even look at the range as the reference, yes. They don't understand positive and negative predictive value and related statistics to interpret true versus false positives. Yeah. And negative interpretations within range versus out of range values, and need to look at several tests to rule in or out a diagnosis. Absolutely. So color coding, red if out of range, if the reference range is appropriate for that person, absolutely, disease specific, age, etc. So this is fantastic. Most of you are already, you don't even need this talk. You know that we have things that we can improve. I'll show you some of our ideas. And I'll show you also how my participants performed. So this was a little study that I did with collaboration of some of the people on this call today. Thank you very much. And it's called Hidden in Plain Sight, Overlooked Results and Other Errors in Evaluating Online Lab Results. So this was when I had them do it, I said, how were there any values outside the reference ranges? So just exactly what you did. And in this scenario, there were 25 participants, just looked at errors, and the thing that would have been different was the timing. So they could stay on this page as long as they wanted to, and they just told me whether I needed to zoom in or zoom out or scroll up or down. So it was totally in their control. I just had to actually be the controller. So I was like the mouse. And if someone said, oh, that one's out of range, then I just asked them to clarify and see what they were talking about. So those were like a little bit of differences between what we just did and what this is. So this, again, here's the report. Here are the values that were potentially abnormal or that we would want to consider later. So here we see that 6 people, they weren't the same 6 people. I went back and looked. I think only one person missed all 3 of them. But most people would catch one or miss 1 or 2, which it sounded like a lot of you did as well. So you might see one, you might not see other ones. And so 6 people of my 25 participants missed each of the flagged results. I also had a couple false positives as well. So people said something that was out of range that actually wasn't. And then 28 of my 25 participants didn't notice anything about the EGFR. And if I was a participant, I wouldn't have noticed anything either, because when I was looking at my stimuli, I didn't notice. So I'm going to talk to you briefly about cognition because I find it fascinating. I think our brains are amazing places, and lots of the things that we do, it's almost like magic up there. But I'm going to talk to you a little bit about fast and slow thinking. So Dr. Daniel Kahneman came up with this idea that we have this fast mode that's rapid, it's super easy, it happens mostly without us really even knowing that it's happening. And because we are managing a lot of information all the time. And then we also have a slower mode that we can switch into when we need to, that requires focus and effort, and it's more conscious. And so when we see software and or displays that are easier to use and easier to understand, we can rely more on our fast thinking and free up resources for more important things like talking to our healthcare providers or coming up with questions or wondering how these things could be better. So one of the challenges that I think that we face in this world is that we're trying to convert tasks that are slow thinking, that are hard for us to do, into ones that are fast thinking. So instead of taking like a big bulky weight, we're trying to do more toning exercises with smaller weights. And we still might want to use the bigger weights, but we want to do them on more important things. So when you figured out which one of these lines is the longest, please pop it into the chat box. Catherine thinks I'm a sneaker and they're all the same. You all think I'm a sneaker. Little monster. You think this is a trick. Dennis is going with 3. Blake's going with 3. Dee Dee's going with 3. Now we're getting some group think going on. Maybe people are like, 3 are the same. What is it? Okay, thank you for playing this game. What I was doing was maybe not making them, oh, we got a 1 in there. I always do this by, like, when you're measuring and you just hold your fingers up and move them around. It's 3. Simon measured. Yeah, I left the display up too long. But what I was doing was not being very kind to you, because I could have lined them up. And this should hopefully make it much more obvious that those of you who guessed 3 were correct. I totally understand that some of you thought I was playing with you, though. But when we do things like organize information like this, which is what computers and health information systems are really good at, is that I just made a task that was harder, that Simon had to measure, into something that the computer took care of that legwork for me and made it something that's easier, and we can use more of our fast thinking. And even beyond that, I could potentially even organize and rank them, which some of you talked about as well, which is great. This is another example. Most of us who learn how to read left to right, if I asked you how many 3s were in this array, you'd go through and look at each potential target and say, is it a 3? Is it not a 3? Is it a 3 or not? And then keep going through until you find them, and then count them up as you go. But again, there are easier ways to do this through design. I could make them pop out at you, and I could use potentially color to bring them to your attention. We can easily also overdo color as well. But what I'm trying to get at here is that no matter what we're doing in the world, I've always visualized it as a pool, since I've heard about this so long ago. I used to think about an above ground pool, because I'm from Ontario. There are lots of those, but it's better with a square or a rectangular pool. Kidney shape doesn't matter. But the idea is that we have only so much cognitive resources that we can allocate to different things. So when we have those tasks, like I made you compare the lines when they were all separate and all over, that is more of a big bucket, and it's taking more of our cognitive resources. Whereas when we use things like organizing them or making them pop out with color, I change that into, it's only taking a small bucket of our cognitive resources. And the idea is that when we use our smaller bucket for things that computers are good at, then we have our more water left over to devote to things like thinking about stuff or understanding or having conversations, again, with our healthcare providers. Okay, so we talked about that already. But I'm going to tell you what we decided were some of the common things that we saw. So it was difficult for our participants to spot the flagged results just in the first place. There were lots of undefined acronyms. These are all things that you came up with. We just kind of worded them slightly different. And also that there was some of that descriptive text that was kind of like a block of text, and you had to see if any of the values that weren't flagged were possibly important as well. And it was difficult to compare the value in relation to the range. We might not have gotten to that one, but I'll show you what I mean in a second. So reasons why, and most of these you came up with, that it was difficult to spot is that our headers, so the flag column actually like scrolled off the page. It didn't stay stable. Also that we were looking for text within text. So it's kind of like a little bit of a Where's Waldo. It didn't really pop out at us, and it blends in. And then in this case, this is one of the changes that I noticed the last time I logged in to look at my results, but the flag was actually the text kind of buried the flag. It was indented over it, whereas now the flag is always like separate and the text is indented in. So again, it's just kind of like we're trying to dig for those flags, and it could be easier. Yes, lots of ways that there are better that we can encode, better ways for us to encode and decode data. Absolutely. Thank you. Thanks for sharing, David. I don't think I've done William Cleveland. I've looked a lot at Tufte's work, but I will look at those. So ways that we can make things pop out are using what we call pre-attentive attributes. These are fast thinking things that just draw our attention. It's probably not working as well here as if I had just shown you a white page with a kind of a periwinkle star or some highlighting. But yeah, so ways that we can draw the attention in easier. We also saw a lot of undefined acronyms. There was lots of space on that report that we could be using. So I think I missed a slide. Oh no. So undefined acronyms was one of the challenges, and then we could actually expand them or even have a hover over, lots of ways that we could make things easier for people to not have to Google simultaneously, like Lisa mentioned. And also we could start thinking about maybe flagging things that aren't traditional values on ranges. So things with binary outcomes. So whether something's positive or negative, it's detected or not detected, confirmed, unconfirmed, or things like color. There might be ways that we would want to flag things there too. So like the EGFR, we could highlight it. And then here we see kind of similar to what they did. So this is what I was talking about, the indenting. But it's also on this, it's different to compare what the value is and put it on this range. So we have to take 53 and then we have to figure out that it's between 45 and 59. So that makes it mild to moderate loss of kidney function. So another way that we could do this is visualize it on a range. And because the range changes in magnitude, that can help us easier integrate information along it. So is it just outside the range, like that 6 that we saw, or is it very far out of the range? And is that range small or is it large? That all depends. So ways that we can integrate this information is helpful. This is just another way that we could kind of visualize that report. So, I didn't change the font. So these were the things that we thought were hard for people, made it harder for them to detect values that were out of range, but also like try to understand what was going on. And ways that we made it use fewer cognitive resources. We're making the flags pop out, expanding acronym, visualizing values on ranges, and then flag values that are possibly important as well. And then we again free up that rest of that water for what does this mean for me, and having better conversations and coming up with better questions when we talk to our healthcare providers. Okay, so I'm going to show you, we're going to keep playing because you're doing so well at this. I'm just going to check the time. What I'd like you to do, I'm just going to show you a lab graph next, and I just want you to kind of come up with a brief description of what the situation is. And then if these were your values, what would you do next? Your results. And if you can, think of something that you might find confusing or could potentially be misinterpreted. Okay, ready and go. Okay. Oops. Does anyone want to give a brief description of what we're seeing in this lab graph, either in the text box, or you're welcome to turn on your microphone? Do I have any brave participants? In the OOR is increasing. Uh-oh, next, eat fewer bananas. Being 1 point out of the reference range, I would put a yellow, not a red icon. Yeah, Catherine's already getting to our solutions. Anything else? So I think we're all seeing an increase here. Looks like my potassium is above the upper limit. Probably call my primary care provider to get advice if I didn't have a medical background. Great, great answer. Okay. So we've got, some people would call their primary care providers. Simon's going to eat fewer bananas. Any other, what would you do next? Steady trend rather than high value alone is significant. Action needed depends on why I'd been tested so often. Yep. Retest. Yep. Good, good, good. Great answers. Thanks everyone for playing along. Did you find anything confusing about this lab graph or that you might misinterpret? No, not a graph. Yeah, not a graph, no trend, two readings, no values on the y-axis. Yeah. No scale on the y-axis. Yep. The slope's also going to change too with how spread out it is on the x-axis. These are great. These are great. Okay. So here's the thing. I didn't know this until I started working with a clinical chemist. And basically, analyte, so potassium is an analyte. It's like a chemical substance that they test. And some analytes vary, and they can vary due to analytics. So it could be like the machine that was tested on. They could just vary day to day within the body, depending on what you eat. Some vary more and some vary less. So we can think about it as a distribution. And what we know, is that some analytes vary more than others. And potassium actually varies quite minimally. So once we have a good idea of where your anchor point is, we wouldn't expect it to necessarily be as high of a range as initially. So this is a tool that's pretty interesting, and it's called the looking for the reference change value, RCVs. And you can look up particular tests. They don't have them for all of them, so it depends. And then they tell you what they expect in terms of analytic variation. So 9% of your original score, biologic variation. And then I changed the range so that it matched what the range was on the paper. And then you can ask for a 95% confidence level. So this is going to tell you what it would expect based on your first result. So, so then you enter your result 1 and you enter your result 2, and then it does a little magic and it says, here's what the regular range was, 3.5 to 5.2. Here's what your kind of personal range would be, knowing how much we would expect it to vary based on analytic and biological variation. We wouldn't expect it to go higher than 4.5 or lower than 3.5. But here we are outside of both of these now with a 5.3. So it is interesting that because we can put some of these things in more context as an individual, it actually means something quite different. And some of you, I'm not sure if you caught it, but this was, yeah, so I didn't catch this as being, I was like, oh, same as some of you might have noticed, is that it's just a little bit out of range. It's not really a big deal. But it also happened within a period of 2 weeks. So you may or may not have seen that based on what you were looking at. But this paper I called false calm and false alarm, because there are ways that our information is presented that, yeah, might make us not worry about it, when really we should be a little bit more concerned and a little bit more proactive. And again, ways that people can be confused by and potentially misinterpret lab results graph. So this one's under review. Plotting it on an SPC chart format could be much more readily self-interpreting. Can you expand SPC for us, please, David?
Yeah, so a statistical process control chart, there's a whole sequence of alternatives depending on the nature of the data, whether it's normally distributed, binomial, small, whatever. It's a standard format that's been used for, I don't know, almost 100 years. They originally were developed for quality control so that a high school dropout on an assembly line could measure anything and see whether or not the machine was drifting out of calibration, could see whether or not something was leading to problems. They have warning lines and action lines on them. There are about a dozen different interpretation rules on them. I've used them in hospital practice, for example, so that people can plot their values and see, okay, like this many points all in a row, all in the same trend line. I better call in the cavalry. You know, um, for my work, hospital infection control, values more than 2 standard deviations had a certain positive and negative accuracy predicting that this is really an outbreak, not a coincidence, as opposed to just random fluctuation less than that. So it's a way of plotting complex data sets so that people who are not trained in statistics, not trained in decoding visual information, have a template on top of a pattern that helps them to say, all right, I better call somebody because this shouldn't be happening by random chance alone.
Yeah, that's great. Thank you. Thanks so much for sharing. And so thanks again for coming today. It's been a while since we've seen each other. Thanks. So here is what I found with my sample. So in this sample, I actually only had 24 participants because my first participant of the whole study was so engaged with this process and had so much to describe that we ran out of time before we could get to this example, which was the first one. But what we did see was exactly what David was talking about, is that we, especially those in the audience today, we probably experience graphs quite frequently. So they're not necessarily foreign. We know what to look at for on the x-axis and y-axis, and we can talk about things like slope and understand those sorts of things. But yeah, people were confused by why the mean was on there because we never talk about a mean when we're thinking about lab results. Some of them were confused about whether the change was important or not, which is where we would want them to get. Like, we don't want them to be, again, with this idea of our pool of cognitive resources, we don't want them to get caught up with things on the X and Y axis. We want those things to be easy to understand, and whether that's something that's visual, or if it's something where we also provide supplementary, like a description, like a line or two to explain it, could be helpful. Some people were confused by the line and the date range and that sort of stuff. And then we also had people who actually misinterpreted things, which I think is potential. Well, it's not, I think it is potentially more problematic, because as soon as we start to misinterpret, we can do the wrong thing more readily. And then our tools aren't being used as tools. They're actually like hindering rather than helping, which is not what we want. So the misinterpretation part happened in some of the similar areas, but fewer people experienced it. And I'll show you some examples of what they said. So here, you'll notice that down here, and I could tell that some people were actually using the information from the table rather than the figure. There is the data point here. These were supposed to pop in. Sorry, I didn't do my animations correctly. But yeah, so first they said it was March 12th to March 24th, but we can see that the actual first value is March 11th, but that's not even labeled on here. As you mentioned, there's no values. I also think it's interesting that it seems like we're blowing through the roof of this chart and we're 0.1 out. Like, it doesn't look like we can get any higher. So that, and we're also like at the very extremes, both maximum and minimum, and widthways as well. So it's not really putting things into perspective necessarily. So this person thought there was only one value because they missed that there's a dot like right on the y-axis. So they only really saw this red one. The line makes it look like it's a huge increase. Again, that could be scale, could be other things. And because they're having, but it is a huge increase. So yeah. And then because they're having tests every day, are they in the hospital? This is the only time I've ever had tests every day. I think there were 3 people who misinterpreted the line as having a data point. And they're like, someone mentioned that it was so linear. And yeah, so things that we might take for granted where we connect 2 data points, other people might not necessarily see. And then it's just a bit above normal. And I do have a reference range for it. I'm not going to be super concerned. And then the warning sign. So again, there's lots of ways that we can potentially misinterpret what's happening here, that this is only showing us a warning sign because it's an important result, but this is the flag that's always used in this example. So only 2 of my participants of the 24 said that because of how much it changed in such a short period of time, that they were going to urgently call their doctor, their healthcare provider the next day. Sorry, here it is. This is the data point that was like right on, and that's kind of the before, and this is the after-ish. So there was also someone that was confused about the date range. We have lots of different ways that we could look at things by month, year, all of it. We could visualize the normal range differently, just have data points, have only dates where we actually have data from, and put things on our y-axis and those sorts of things. And then also use kind of something that's a little bit more neutral, and orange instead of like a warning sign. The other thing that we can do is, like I talked about before, knowing what we know about potassium, and then it's actually like quite a bit more bound within an individual. We could actually display a personal range, and then we would see that it's quite a bit outside of what we would expect. So that's going to communicate things differently as well. I'm just going to check for time. I think I'm going to skip this last example, but I have all the references and you'll have my email address. So you can always email me and I'm happy to talk about this stuff, but I really actually want to get to conversation. I'm just going to briefly talk about this one, but we won't do it as an example. This was that same graph that I showed you, but it was also adding complementary text about potassium and some of the interesting findings here. So this was good because people really appreciated having high quality information associated, that it was right there. They didn't have to even click off anything to go find it. They didn't have to know in their Google search or in now their Chat GPT, like whether or not it was a credible source of information or anything like that. So it has lots of things about the test, why you take the test. And then it talks about the potassium level being only slightly out of range. Sorry, I have a frog in my throat. But what we did see were that this is not a number of participants. This is just number of codes that we saw. But lots of people were really actually quite pleased about this. They're like, I like that it's something that's trustworthy, that goes along with what I'm looking at right then. But they also found it was a lot of information and not all of it was relevant to them. So there was some evidence of information overload. They also got confused by things. And again, we saw some misinterpretation as well. So one of the things that I remember striking me was that someone in the interview was like, I should eat more bananas. So instead of thinking about their potassium being too high, they were actually reading about how spinach and bananas can improve. And so they were going to eat more and potentially exacerbate a situation. This is just so you can see, these were the 4 examples that I showed them. So this was the one that you saw, and then you also saw 4. So you saw 1 and 4, but I also showed them 2 where I just kind of like expanded acronyms. And then 3 was the reason that I got interested in this. This was from a design competition for Wired magazine, and they recognized in 2011 that lab results weren't doing many people justice and helping them understand things. So designers got involved and redid it. And then I got in touch with the designers who won the competition. And then they gave me this one. People didn't like having their photo on it, but otherwise this one was their favorite one out of the 4. It was the only one that's statistically different anyways from the least favorite one, which is how the first example that you saw. And here we see, so not only is it color coded, which has some problems, and there are some problems with some contrast and color vision deficiency, friendliness, and that sort of thing. But it does give you little blurbs about what your results might mean and things and actions that you can do next. But they really didn't like to know about, didn't want to hear about their dying from coronary disease. That is not what they wanted on the reports. So some kind of high level summary of my findings is that people really like this, but they like getting access to their results. But there are lots of different reasons why it might be hard for people to identify abnormal results. So they looked at the results because usually they're looking for abnormal results and potentially trends over time. They might be monitoring something in particular because they're on a new medication or as part of their disease management or that sort of thing. Flagged results, as you saw, can be easily overlooked in one of the most common ways that we get access to our lab reports. And people can get confused by and misinterpret this information and the complementary information as well. And then there are some design changes that we could be making that would improve the way that we communicate things. So there's so many ways that we can do it. But what I'd like to do now is open up for, in these last 15 minutes, is get a little bit more on your perspective. So either as a consumer or as a healthcare provider, I'm interested in knowing what you like about this increased access to lab results, whether they're lab reports or graphs. Welcome to chat or put in the chat box. Decreased delays in care. Yeah, A 1 in X way of expressing risk is definitely not optimal. It's a theater of risk. Yeah, more like a constellation. Absolutely. It's a permanent record. Yeah. We can go back to it and look at it at any time. Anything else that we like about it? Lots of times gives you more peace of mind, assurity than the no news is good news. Oh, Alana, I know that is like my least favorite saying. I was always like, my lab results are going to be the one that fall to the floor and someone's not going to find them. And yeah, so I think like, and I feel like we're never as anxious as like when we go and get those tests, you know, like it's like, okay, so I'm doing the right thing. I'm getting my preventative screenings done or whatever, and then you're like, oh my gosh, but what if I have this? And then so when we get that back sooner than we might actually hear from our healthcare providers. Absolutely. Did you have something that you wanted to comment on?
And being like both of us being interprovincial, having had tests back home, and obviously there are thresholds for different levels of things like white blood cell counts, etc., that are deemed as normal, but not everybody falls perfectly in those lines. And so having had those tests in a different province, but then coming here and having new doctors and them conducting similar tests and seeing these numbers that they don't feel are completely accurate to what should be the normal, it's kind of nice to be able to say, well, I've actually seen this test multiple times over the course of my life, and I know that that's my normal.
Yeah. And I think that's a really great point too. I don't like the word normal necessarily. And that's why like moving towards personal ranges is I think like a great way to go. Like you said, some people, even small changes can be really like indicative of things going in the right direction. And I think that we need that sort of feedback loop to be like, okay, the diet and exercise changes that I'm making, or the medication is working, or those sorts of things. So the more we can tailor to the individual, I think the better. Because yeah, it's normal is just, it's not necessarily, it's average for most people in the population, but there's also lots of flaws with that. I don't think my colleague, Dr. Dana Bailey, is here, but she's the clinical chemist I've been working with, and she has tons of things to say, especially about like females and how iron isn't necessarily representative because of menstruation and all that sort of stuff. Dr. Les Raw says, I think the access to information can stimulate a more robust discussion with the healthcare team. Yeah, I think that's right too. And like, that's again, the mission for all of my work is that I think we have such limited time with our healthcare providers. How can we get people to a foundation where they can understand more when we have those limited encounters or ask great questions? I think Aaron also said that, yeah, not having to bug the doctor's office and not having to wait. Absolutely. These are great. Okay, next conversation. Point here. I can't see it because of Zoom. Zoom's got room for improvement. What are the challenges? What challenges are created, because consumers have access to their lab results? So this is more for our healthcare providers out there. Are you seeing anything that is detrimental or that you didn't see before we had this increased access? No, it's all good news. Okay. Not answering your question. Okay. But out of range results are significant, but sometimes it's important, the relationship between the out of range and normal. So out of range A and normal B can be more serious than out of range A and out of range B. Yeah, absolutely. It's very contextual. Thanks for sharing, Mike. When patients' access is immediate and it's not good news. That's actually been in the news, the news media recently. There was a really good CBC interview about people getting like cancer diagnoses through accessing their portals. And I think that is one of the new challenges, is it does bring a lot of us peace with that no news is good news. But I know for myself that if there was something that someone else felt that I should be talking through with a healthcare provider, then I would opt in for that. And I'd be like, don't show me my results if there's something that is serious or that I should be sitting down for, or shouldn't misinterpret on my own, or interpret or try to interpret on my own. Patients who misinterpret their lab values are often panicked while waiting to see their physician in follow-up. Absolutely. So it's a trade-off. Sometimes we're reducing anxiety, sometimes we're artificially increasing anxiety because we're like, oh, we're out of range, but really it doesn't really mean anything. Or it could be one of those ones that has large biological or analytic variation. Misinterpretation by people who don't have the education and experience of physicians, false positives, psychological harm thinking. Yeah. So we're getting trade-offs. Absolutely. Thinking of abnormal results as proof of disease. Yeah, it's not so simplistic. Seeing some dissatisfaction from patients because they feel the clinician isn't responding or updating them in a timely fashion. Several stories of delays in care for the patient are recognized. Worried well and hypochondriacs. Yeah, or the cyberchondriacs. Thanks, Mike. In the US, where you may get a pathology report immediately through my chart, will trigger the doctor that you saw it, and then they will contact you much quicker and talk about it. Yeah, I was actually reviewing something recently, and it talked about the timing. So like Monday to Friday versus things being released on weekends, and how that impacted follow-up care. Absolutely. Oh, thanks, Elizabeth, for joining us. Thanks so much for attending. Okay, thank you. So I do have another question. Otherwise, in BC, you might wait long times to hear anything back. Yeah, or you might have to be the one who instigates. In my interviews, I had one participant who said that it was life-changing for her to have access. The result indicated that she was in heart failure. So she went to the emergency room right away and got care faster than she would have had she left it. Thanks, Blake. Thank you so much for joining us. Okay. All right. Okay. And I have one more question, which was related to that one. Do you think that all lab results should be accessible to consumers or not? Thank you, Nan. I can't see anyone. So things to think about. I just wanted to thank all of my amazing collaborators. As I mentioned, a few were on the call today. Thanks for your support. And my amazing students over here. They've been super helpful in all of this. And nothing I do gets done by myself. So thank you, everyone, for all your support and help. And thank you for showing up today. And this is my email address, but I'll pop it in case you want follow up on any of these studies, or if you want to talk more about this. Thank you, Erin. I'm going to stop sharing. Thank you. Thanks, everyone. Great discussions. Thank you for participating. Thanks, Dennis.
Thank you very much.
Thank you.
This is the most